In this lesson, we're going to cover artificial airways. Now, this is something that isn't covered very well in most nursing programs, and students sometimes find it hard to identify which airway to use in which situation. So we're going to break it down really simple for you so it's easy to understand. Now, there's only one general reason why a patient will require airway management, and that is airway obstruction. Now, I'm not talking about those who aren't breathing at all. We know they need to be on a ventilator. I'm talking about people who cannot protect or manage their own airway. So this might be a physical obstruction, like they're choking, but the most common things we see are tongue obstructions from it falling back in the mouth and excessive secretions that the patients can't clear. So what happens in a patient who's unconscious is their tongue tends to fall back in their throat and it occludes their airway. So when that happens, it's really difficult. You may hear them gasping or snoring if they're even breathing at all. So there's a couple maneuvers we can do before we even put in an artificial airway. One of those is the head tilt chin lift, like you see here. We're going to tilt their head back and we're going to lift their chin towards the sky. And that will help to pull that tongue off away from the airway so it's no longer blocked. Now, if you have a patient who is in C-spine precautions, you're going to need to use the jaw thrust maneuver instead so that we don't jack their head back when they have C-spine fracture. And so what we do instead is we get behind the mandible and we push up. Or you could even lift up on the chin. Either way, the goal is just to push the jaw forward and not to tilt the head back at all. Either way, it's going to help us pull that tongue up out of the back of the airway. So when these things don't work, this is when we move on to artificial airways. So let's cover them one at a time. Now, the least invasive option is our nasopharyngeal airway, also called a nasal trumpet. The main indication for this is someone who is breathing independently or at least making really good efforts. They're just struggling to clear their own secretions. They've got lots of sputum, lots of things blocking their airway. So our goal is to insert this flexible rubber tube into the nose, and it'll land right here in the back of the throat so that we could then insert a suction catheter and clear some of the secretions from above their airway. Now, we need to make sure we have the right size, so we're going to measure from their nose to the corner of their jaw, the angle of the mandible, to make sure that we have the right size tube so that we're getting exactly where we want to get and get these secretions out. Now, a key thing to note here, these patients are usually conscious. It isn't contraindicated in an unconscious person, but if they're unconscious, we're going to need another intervention to be able to pull that tongue out from the back of their throat. So we're going to move on to the next artificial airway, which is called the oropharyngeal or the oral airway. Now, the oral airway is only used on unconscious patients. It's a rigid plastic hollow tube that looks like this. Can you imagine if you were awake and somebody shoved that in your throat? You would gag on it, right? So unconscious patients only. Typically, this patient's the one who's gasping or they're snoring because they're unconscious, and now their tongue has slipped back in the back of their throat and it's blocking their airway. So when we insert this oral airway, we're again going to measure from the corner of the mouth to the angle of the jaw to make sure we're getting into the right place. And when we insert it, we're going to pull their tongue forward and insert this hard plastic tube so that it keeps their tongue out away from the back of their throat. And again, because it's hollow, we can also suction through it to get any secretions out if we need to. Again, only unconscious patients and only if they're breathing or trying to breathe. So what do we do if we have a patient who isn't breathing? That's when we move on to the endotracheal tube or the ET tube. Anytime we talk about a patient being intubated, this is what we're referring to. We intubate patients who are either not breathing at all or at least not breathing effectively, or who simply can't protect their own airway no matter what we try. And then, of course, we'll also use this for any patients who require mechanical ventilation. As you can see here, the endotracheal tube is inserted through the mouth. It passes through the vocal cords and into the trachea. And then this balloon that you see at the end here is inflated. Now, we inflate this balloon not to anchor in place, although it does that a little bit, but not really. We do that because we're going to be attaching this to a circuit and attaching it to a ventilator. We're going to be providing positive pressure breaths through this tube. So when we push all that positive pressure in here, if this balloon isn't inflated properly, all that air is just going to come right back out. So we leave that inflated. Now the blue thing you see here, this tube coming off here, that is your balloon port. This is what you use to inflate that cuff, and you have to protect this at all costs. If it accidentally gets cut or broken or pulled, this balloon is going to deflate and you're losing your airway. You have to replace the whole tube. Now, a key point to note here is this is considered an advanced airway, and it is only inserted by providers. This could be an NP, a PA, MD, DO, CRNA, an anesthesiologist, respiratory therapists in some states are qualified, paramedics are qualified. It's very, very rare, but in some states, RNs can have special certifications to do this. But for the most part, it's outside of our scope of practice. What we can do, though, is recognize the need and call for help if we need it. Now, the last advanced airway is the tracheostomy. Now, there's a variety of reasons why we might need to use this, and you may even see an emergent tracheostomy done for somebody who has a physical airway obstruction that we can't remove any other way. Now, we'll also use a tracheostomy for patients who are struggling to wean off of the ventilator. This shorter tube makes it much, much easier for patients to breathe and do their own respirations because there's less resistance. Imagine trying to breathe through a long soda straw versus getting a smoothie straw that's wide and cutting a short piece of it and breathing through that. It's much, much easier. So because we can decrease this resistance, it makes it much easier to get them off the ventilator because they don't have to work as hard. The other reason that why we might use a tracheostomy is for long-term requirements. Patients who have things like ALS or quadriplegia, or even patients with things like tracheal cancer who've had tracheal damage are going to need a ventilator or need a tracheostomy long-term and possibly even ventilation. And so that's another reason why we might put in a tracheostomy. Now, there's a lot of different types of tracheostomies depending on the need. Some have cuffs like you see here that allow for that positive pressure ventilation, just like with the ET tube. Some of them will have a hole in them called a fenestration that actually allows patients who are weaning to be able to breathe through their trach and past their trach to start learning how to breathe normally. And then others don't have a cuff at all. It just depends on what your patient's needs are. When we do trach care, we're going to pull this inner cannula out and we're going to clean it. And then we're going to change these ties like you see here. Those are big things for trach care in addition to actually cleaning around the tracheostomy. Big safety tip here. This little plastic doohickey right here. Yep, doohickey is a medical term. This plastic thing is called the obturator. The obturator is what we will use to replace the tracheostomy if it accidentally becomes dislodged. You have to have that obturator or you will not be able to put it back in. And so what we usually do is we'll put it in like a little plastic baggie and we'll put it and tape it up over the bed, tape it to the wall. So always know where your obturator is and make sure you look for it and know where it is if your patient has a trach. Now, again, this is also an advanced airway, so you're going to need a provider, usually a surgeon, to put this in. So let's look at what this decision-making process looks like for you as the nurse. First things first, assess their airway. Is it open? Are they protecting it? Or do you hear that gasping and snoring sound? If you determine they aren't protecting their airway, we need to find out, are they physically breathing? Are they putting forth respiratory effort but just struggling with their airway? Or are they physically not breathing at all? Then we're going to assess their level of consciousness. Are they conscious? Are they unconscious? If they're conscious, your only option is a nasopharyngeal airway unless they are struggling to breathe and need to be intubated. If they're unconscious, the best option is the oral airway. Now, if they are not breathing, then we know we need an advanced airway. So we need to call for help. We're going to get an RT, we're going to get the provider, call rapid response, whatever you need to do. And a lot of times what we'll do is we'll insert an oral airway, and that will help to open up their airway. We'll use a bag valve mask to help ventilate them, and we'll keep doing that until the provider arrives to secure their airway with an endotracheal tube. Okay? So make sure you check out the cheat sheet attached to this lesson. There's an awesome decision tree that goes through the same process we just talked about to help you understand what's the right artificial airway for your patient. All right, guys, go out and be your best selves today. And as always, happy nursing.